Hello, everyone. My name is Martin Reck. I'm a pulmonologist. I'm working on thoracic oncology in a lung cancer center in the north of Germany, very close to Hamburg. And I had the pleasure to attend the ELCC this year in Paris. And it was also my pleasure to speak on one of the symposia that was organized with the title New Immunotherapies in Management of Patients with Advanced Non-Small Cell Lung Cancer. And this really has been a very, very interesting session, touching all the fields of development that we do see for this new opportunity of immunotherapy. And I started with a lecture about new checkpoint inhibitors. We do have seen very sustainable data for the inhibition of PD-1, PD-L1 with the anti-PD-1, anti-PD-L1 antibodies. We have anti-CTLA-4 now in our armamentarium for immunotherapies. But besides that, there's a huge variety of new checkpoint inhibitors in development. We have anti-TIGIT antibodies, anti-LAG, we have anti-TIM3 antibodies, and many, many more where we have seen the first signals in clinical trials. We will need the confirmatory trials to see the true value of these new checkpoint inhibitors. This is work which is currently ongoing. What we have learned so far is that indeed the majority of these new checkpoint inhibitors require a combination with an anti-PD-1, anti-PD-L1 antibody as a backbone. They do not really work sufficiently alone, so they really require the combination. And this brings me to my next topic, because the next talk was about the bispecific antibodies. And this is the concept that you do have two immunotherapies in one molecule. You are inhibiting two pathways. You are interacting with two different pathways. We do know this concept from hematological malignancies, but now the majority of bispecific antibodies is developed in the field of solid tumors. And when we look on T-cell engaging, when we look on immunoediting bispecifics, there is a huge variety now in clinical development. And we have seen quite encouraging early signals in patients with untreated non-small cell lung cancer, but also in the difficult setting of immunotherapy refractory non-small cell lung cancer. So we might expect a lot of exciting new data and perspectives for our patients in the near future. Besides the bispecifics, which incorporate a combination of checkpoint inhibition in one molecule, we also have the field of vaccination. This was the third talk. Melissa Johnson talked about new vaccine strategies. And I have to say, well, in lung cancer, we do not have that good experience with vaccination strategies. We have a couple of negative trials with old vaccines. However, now we have undergone some thorough revision of our concepts. We have got new vaccines, we have got personalized concepts of vaccines, and now we really do see quite encouraging signals in immune activation. This has to be transitioned to clinical improvements, but this is something which is now going on in a number of prospective clinical trials. And the last talk was a little bit looking on the horizon, what might come up in the next years. This was about cellular therapies. This is a very, very exciting topic where we can induce very long-lasting controls of tumor diseases. Ben Creelan presented some examples. He has performed himself a trial on tumor-infiltrating lymphocytes as a novel concept of personalized immunotherapy with very encouraging data. There are some challenges with the tolerability, with the manufacturing process, and so on and so on. And it remains the question whether this will be a general opportunity for all of our patients, but we do see clear signals of efficacy. And this is also a field which is moving very fast ahead also in patients with solid tumors like patients with lung cancer. So overall, we have a big universe of new immunotherapies coming up for patients with advanced non-small cell lung cancer. We had an updated survival on the amivantamab combination data in EGF receptor mutated non-small cell lung cancer. So we do see now with more maturation of data, a more solid signal also in improvement of overall survival for the combination of osimertinib and for the combination of lazertinib and amivantamab compared to osimertinib alone. We had a couple of talks on targeted therapies, new approaches. We had also a lot of posters from young investigators looking on different features of immunotherapies, but also on translational results, looking on immunogenicity of solid tumors, pictures of immunogenicity, mechanisms of resistance. So there were a lot of things to discuss and to talk about. But I think for when we talk about stage 3 and novel immunotherapies, these were the major facts which were presented.